Now, our next speaker was the former Health Resources and Services Administration, known as HRSA, Associate Administrator of the Maternal and Child Health Bureau. He recently took a position as Professor and Senior Associate Dean for Academic Faculty and Student Affairs at George Washington University. Dr. Liu and I walked in together, and I said to him, "Oh, so from where are you?" So he said, "Washington, D.C." So I said, "Oh, Chocolate City." He said, "What's that? What do you mean by that?" I said, "Well, evidently you don't look around too much. It is Chocolate City." Welcome now, Dr. Michael Liu.
Thank you, Patty. Thank you and good morning. I am so very honored to be invited to speak at the summit. So I just want to start by thanking Commissioner Box and the Planning Committee for the invitation. And as some of you may have heard, I left the Maternal and Child Health Bureau a month ago. So I also just want to take this opportunity to say thank you to so many of our partners in the room today. I want to give a special shout out to Martha Ellen, your State Title V MCH Director, Shirley Payne, your Children's Special Healthcare Needs Director, and all the amazing people we partnered with over the last few years who work for your state Title V program, home visiting, Healthy Star, EMSC, Family to Family, and many, many programs that serve children and families in your states. Thank you for all the trust, the support, and the partnership that so many of you have so generously gifted me over the last 6 years. And thank you for all that you do for children and families in Indiana and for our nation. Thank you. I was asked to talk about ACEs, Average Childhood Experiences. But before I start, I want to take a moment to talk to you about the American dream. I want to talk about the American dream because it is what unites all of us in this room. It's what our work in maternal and child health is all about. To give every child, every family, a fair shot at reaching their fullest potential. To give every child, every family, a fair shot at the American dream. It's a dream of freedom and individual rights, inspired by a simple proposition some 241 years ago, that we hold these truths to be self-evident, that we're all created equal, that we're endowed by our Creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. It's a dream of equality of opportunity, that everyone gets a fair shot, no matter where you're from, or the family that you're born into, or the color of your skin. Summed up by historian James Truslow Adams in 1931, who popularized the term the American dream. It's a dream of a land in which life should be better and richer and fuller for everyone, with opportunity for each according to ability and achievement, regardless of the fortuitous circumstances of birth or position. Regardless of the fortuitous circumstances of birth or position. And it's a dream of intergenerational mobility, that in every generation, children should live better than their parents did. 50 years ago, on the steps of the Lincoln Memorial, when Dr. King told us about a dream that he had, when he said that, "I have a dream that my 4 little children will one day live in a nation where they will not be judged by the color of their skin, but by the content of their character," he was talking about the American dream. I want to talk to you this morning about the American dream, just to remind you that's what our work in MCH is all about. In fact, I believe that our work in MCH is foundational to the American dream, that your rights to life, liberty, and the pursuit of happiness have everything to do with your capacity to exercise them. That you ain't created equal. If you can't get an equal start, you don't get a fair shot if you can't get a fair start. And that if we want our children to have a better life when they grow up and to do the kind of things that we couldn't even dare dream of, we start by investing in maternal child health. I also want to talk to you about the American dream because I believe that the ACEs are killing the American dream. And that if we're going to restore the American dream for the next generation, we really have to do something about the ACEs. So what are ACEs? ACEs are average childhood experiences, which is probably one of the biggest public health problems in our nation today that most people haven't heard about. ACEs are defined as abuse, neglect, and household dysfunction in childhood. And let me just make 3 points about the ACEs. ACEs are too common, ACEs are harmful, and ACEs are preventable. So first is that ACEs are common, tragically all too common in this country. Now, according to a landmark study of more than 17,000 adults at Kaiser San Diego who were surveyed about their experience of childhood abuse, neglect, and family dysfunction while they were growing up, for abuse, 29% of those surveyed reported a history of physical abuse. 29%. 21% reported sexual abuse, 11% emotional abuse. For neglect, 15% reported emotional neglect, while 10% reported physical neglect. For household dysfunction, 27% reported substance abuse in the household, 27%. 23% experienced parental separation or divorce, 19% reported mental illness in the family, 13% witnessed mothers treated violently, while 5% reported incarceration of a household member. So overall, in this middle-class, well-insured population, we're not all that different from you and me. Nearly 2 out of 3 adults surveyed reported at least one average childhood experience. More than 1 in 3 experienced 2 or more ACEs, and while 1 in 8 experienced 4 or more ACEs growing up. Now, since that landmark study, many states have looked at their ACEs in their states using BRFSS and found similar results. Unfortunately, Indiana is one of the states that haven't looked at your state's ACEs data. But fortunately, I do have the latest ACEs data for Indiana from the Bureau's 2016 National Survey of Children's Health, hot off the press. The survey is based on parent report of more than 50,000 children nationwide, including a representative sample of more than 1,000 children in Indiana. Now, our survey doesn't include questions about abuse and neglect because it's based on parental survey, but includes items such as neighborhood violence and unfair treatment based on race. Now, based on our 2016 survey, nationwide, nearly half of children 0 to 17 years old have experienced at least one ACE. That's nearly 35 million American children nationwide. And more than 1 in 5 children have experienced 2 or more ACEs. That's more than 15 million children who have been exposed to 2 or more ACEs. Now, what about for Indiana? Right here in Indiana, nearly half of children 0 to 17 old have experienced one ACE, while 1 in 4 have experienced 2 or more ACEs, which translates to more than 373,000 kids in Indiana who have been exposed to 2 or more ACEs. Now, who are these kids? ACEs cut across all socioeconomic strata. While ACEs are more common among poor kids, our survey found that 39% of poor children in Indiana have experienced 2 or more ACEs. Still, 1 in 8 kids growing up in families with household income above 400% of poverty have also been exposed to 2 or more ACEs. Similarly, ACEs cut across all educational levels, such that while 39% of children in Indiana born to parents who are high school graduates have been exposed to 2 or more ACEs, still 1 in 6 kids in Indiana born to parents who were college graduates have also experienced 2 or more ACEs. There are racial ethnic disparities in ACEs, with 17% of Hispanic kids, 22% of white kids, and 41% of African American kids in Indiana having been exposed to 2 or more ACEs. Now, that said, I want you to take a look at this data based on our 2012 survey, and that's because we haven't done similar analysis on our 2016 data. First, for all groups, there is a socioeconomic gradient in ACEs such that poor kids are more likely to be exposed to 2 or more ACEs. Second, for all groups, kids born to US-born parents are much more likely to be exposed to 2 or more ACEs than kids born to immigrant parents. And third, amongst US-born families, Black and Hispanic kids are more likely to be exposed to 2 or more ACEs than white kids across all income groups, with one exception. Poor white kids are more likely to be exposed to 2 or more ACEs than any other kids. In fact, nearly half of all poor white kids in America have been exposed to 2 or more ACEs. And lastly, ACEs vary by family structure. So while less than 10% of Indiana kids born to married parents have experienced 2 or more ACEs, more than 1/3 of kids born to unmarried but cohabiting parents, and more than half of kids born to single mothers have been exposed to 2 or more ACEs. Bottom line, too many kids in Indiana and in this country are exposed to average childhood experiences. The second point I want to make is that ACEs are harmful. Now, some of you might be saying, well, so what, right? Many of these kids will rise above their adversity. In fact, the adversity may even make them stronger. My second point is that ACEs are harmful to your health. ACEs can lead to social, emotional, cognitive impairments, health risk behaviors, disease, disability, social problems, and even early deaths. Here's a whole long list of health and behavioral problems, from developmental delays to risky sexual behavior to obesity to smoking, lung disease, ischemic heart disease, that have been linked to ACEs in a clear dose-response relationship. The more ACEs, the greater the risks. From a population health perspective, in terms of population attributable risks, ACEs may account for up to 25% of cancer and heart disease, 50% of all mental health problems, 60% of HIV risk, just because they're so prevalent. The CDC estimates that people with 6 or more ACEs die 20 years younger than people without any ACEs, and that the total lifetime cost associated with just 1 year of confirmed child maltreatment cases has been estimated to exceed $124 billion. Now, some of you might be asking, how? How does what happened to you when you were a child increase your risk for disease, disability, and premature death as an adult? Biologically speaking, we know that toxic stress from ACEs can disrupt normal brain development. It can actually reduce the number of synapses inside the brain, and this is particularly damaging in early childhood when more than 700 synapses are formed every second. We also know that toxic stress from ACEs can reprogram the child's stress response. It can turn on genes in areas of the brain that accentuates or rev up your stress response, and turn off genes in areas of the brain that modulates or breaks your stress response. So you end up with a child with a more hyperactive stress response who's always in a fight or flight mode. Now, while that heightened stress response may confer a survival advantage in the short run, it can interfere with the child's ability to focus, to learn, to connect and relate with others, which we know are so critically important for success in school and later in life. It can also create, over time, wear and tear on the body's vital organs and systems, leading up to hypertension, diabetes, obesity, heart disease. It's like if you keep gunning the engine, over time you're going to wear out the engine. If you keep riding the brakes, over time you're going to wear out the brakes. So if you keep stressing the body, sooner or later you're going to wear out the body. Now, pregnancy itself is a major stressor on the body. A healthy body might be able to adjust and adapt to it, but the body with worn out neuroendocrine, immune inflammatory, metabolic, or cardiovascular system might not, which puts both the mom and the baby at greater risk for pregnancy complication. And that's how mom's average childhood experiences can lead to baby's adverse birth outcomes. The toxic stress from ACEs could alter early programming of mom's stress response, which could go on to affect her future reproductive outcomes. Staying with the theme for this morning, I also want to just take a minute to draw the connection between opioids and the ACEs. As you heard today, opioid misuse during pregnancy is a growing problem, both in the US and right here in Indiana. Both opioid use among pregnant women and NAS have increased by a 5-fold in a decade, and nationwide it is estimated that more than 21,000 pregnant women misuse opioids during pregnancy every year. Opioid misuse is harmful to both mom and baby. We're now getting increasing reports of maternal deaths due to opioid overdose, often in the postpartum period when access to medication-assisted treatment is discontinued. A recent report from Texas, based on review of actual case records, including postmortem toxicology and police reports, show that drug overdose is now a leading cause of maternal deaths in Texas, with the majority of maternal deaths involving prescription opioid overdose. You'll hear more about NAS later on today, but we do know that some 70 to 95% of babies born to opioid-dependent women will have NAS. And studies have also made the connection between parental substance abuse and child abuse and neglect. The statistics vary, but studies have shown that between 1/3 and 2/3 of child maltreatment cases involving substance abuse, and we have increasing reports that the opioid crisis is straining our nation's foster care system. So we know that parents' opioid use and addiction is an average child experience for their children, but what's the connection between the parents' opioid addiction and their own experience of ACEs? Indeed, childhood trauma and abuse have been linked to substance abuse in adults, including opioid addiction, and a recent study using data from National Longitudinal Study of Adolescent and Adult Health found that experience of childhood physical and emotional abuse was significantly associated with opioid misuse in adulthood. And if subsequent studies can confirm this relationship, then I believe that preventing ACEs has to be central to our national strategy for addressing the opioid crisis right here in Indiana and in our nation. Third is that ACEs are preventable. So what can we do about the ACEs? By preventable, I mean primary, secondary, and tertiary prevention. Primary prevention is about preventing ACEs from happening in the first place. That starts with family planning to prevent unintended pregnancies, support parenting through evidence-based programs like 3Ps or home visiting, increasing access to mental and behavioral health services, addressing social determinants of ACEs, including poverty, unemployment, father absence, and racism. And we must also re-examine public policy that exacerbates family dysfunction. For example, the marriage penalty, under our tax or welfare or child support policy that discourages father involvement, or our law enforcement that criminalizes opiate misuse during pregnancy that breaks up the family, or the disinvestment in our inner cities that are creating hyper-segregation and hyper-concentration of poverty in communities of color. So if we want to prevent ACEs, we've got to take on these social determinants that are the root cause of much of the ACEs. Secondary prevention is about screening and early intervention. Pediatricians are on the front line. They need to do a better job at screening for ACEs. The AAP has put out a guidance with a 4-step process that practices can use to begin to identify ACEs. But it really shouldn't be just the pediatrician doing it. ER docs, OBGYNs, family practitioners, internists, nurse practitioners, and all healthcare providers and their office staff should also be screening. And it really shouldn't be just healthcare providers doing this. Early childhood development workforce, child care providers, early Head Start and Head Start teachers, home visitors, as well as primary school teachers and staff, everyone who come in contact with the children should be knowledgeable about ACEs and have a responsibility for prevention. Tertiary prevention is about preventing the harmful consequences of ACEs once they've already occurred. Treatment of depression, opioid addiction, and other physical, mental, and behavioral health consequences of ACEs are important, but I think building resilience in those already affected by ACEs is key. Recent data from Dr. Bedell at Johns Hopkins, who's done some of the best work in this area, show that resilience can buffer ACEs. Resilience moderates the impact of ACEs on health. But the big question is how? How do we build resilience? The good news is that we now know that epigenetic changes from childhood adversity are not permanent, that they are reversible, that the window of reversibility may be wider than previously thought, may extend well into adulthood. So for younger children, secure attachment relations, enrichment opportunities, clinical intervention, and a trauma-informed 2-generation approach can make a difference. For adolescents and adults, there's some work looking at mindfulness, mastery, transcendental meditation, cognitive behavioral therapy, and that's at the individual level. I think at the interpersonal level, promoting interpersonal communication and negotiation skills and strengthening father involvement are going to be key because family and social support are a very vital source of resilience. And much less is known about building resilience at the community level. A notable example is Children's Resilience Initiative in Walla Walla, which transformed an entire school into a trauma-informed school and dropped its suspension rate by 85% in 1 year, and then transformed an entire community into a trauma-informed community. This also reminds me of a project that I worked on years ago while at South Central Los Angeles with an organization called African American Families. Now, Healthy African American Families works in the community to fight the high rates of infant mortality in that community. And it started by doing these focus groups of pregnant women. You ask the pregnant women, what are things that stress you out during your pregnancy? And then you ask 2 more questions. What can families and friends do for you to help you have a better pregnancy? And what could strangers do for you to help you have a better pregnancy? Well, guess what the pregnant women were telling them? What do you think they want from families and friends? Help me with the dishes, help me with childcare, help take me to the prenatal care. A lot of this was actually directed toward the male partners. Okay? But what do you think pregnant women wanted from strangers in their community? Well, the most common answer was, don't come up and touch my belly without my permission. But we also heard a lot of, offer me your seat when I get on the bus. Or let me go to the front of a line when I'm waiting in the grocery store. And growing up in Taiwan until I was 11 years old, everyone knew that when a pregnant woman gets on the bus, or when a woman with young children get on the bus, you'd be so ashamed to stay seated. And so when a pregnant woman gets on the bus in Taiwan, everybody stands up. Okay? But somehow we lost that in this country. So what Healthy African American Families did was they then compiled this list of 100 things that families, friends, and strangers can do to help pregnant women have a better pregnancy, what they call 100 intentional acts of kindness toward pregnant women. And the whole idea behind it is that even if we can't completely reverse structural racism, even if we can't do away with all the things that puts a toll on pregnant women, there are things that we as a community can do to provide social support, social capital, and to build community resilience to support a healthy pregnancy. So I just want to close by coming back to the American dream. I truly believe that in the richest nation on earth, we ought to be able to give every child and every family a fair shot at reaching their fullest potential. Now, we can't guarantee outcomes, but we should always guarantee a fair shot. That's this nation's promise. That's what makes America great. And that's what has drawn generations of immigrants from distant shores. Immigrants like my parents, who set forth years ago to America looking for that fair shot, not necessarily for themselves, but for their children. See, I was born to immigrant parents who never went to college. In fact, my mom, she actually never went to high school or even junior high. See, my mom was only 11 when her father died, so as the oldest daughter in the family, she had to drop out of 5th grade to go work in a factory. So when I was born, we were still pretty poor. The first house that I was born into was this tiny little apartment on the other side of tracks in Taipei where family of 6 was crammed into. No running water, no flush toilet. Health insurance? We didn't have health insurance because there wasn't such thing as health insurance back then. And so when a child gets sick, and unfortunately I was sick quite a lot as a kid, you never know how much the doctor or the medicine was going to cost. And my parents often have to make that choice between paying for food and paying for medicine. And at one point, my mom sold her wedding ring for my medicine. But none of so I didn't come from an educated family or a wealthy family. But none of that mattered anymore once we came to this country. It didn't matter because the American dream says that you don't have to be rich to go to the best schools. And it didn't matter because the American dream says that everyone deserves a fair shot, no matter where you're from, or the family you're born into, or the color of your skin. And it didn't matter because I knew that if I just work hard enough and try hard enough, I can give my children a better life, the kind of life that my mom could never even dare dream of. And that my 2 girls, the granddaughter of a girl who had to drop out of 5th grade to go work in the factory, can now grow up in a nation where they get to be anything they want to be. That's a true testament to the enduring strength of the American dream. That's what makes America great. And if my girls can have that chance, why shouldn't every child in America get the same chance? If my girls can have a fair shot, why shouldn't every child get a fair shot? This is what we're fighting for. This is what this summit is all about. This fight is bigger than ACEs or opioids or infant mortality. This is a fight for who we are as a nation, as a people. This is a fight for that America that perhaps has never been and yet must be. And even though I left the Maternal Child Bureau a month ago, that doesn't mean that I'm quitting the fight. I'm going to keep on fighting every day for the rest of my life, and I ask you to join me. If you still believe in America's greatness, if you still believe in the American dream, please join me, and together let's fight to give every child and every family in Indiana and across the nation a fair shot at reaching their fullest potential, because ultimately that's what the American dream is all about. Thank you very much.